Hey guys, let's talk about tumors of nasopharynx. So the nasopharynx is a part of pharynx which is directly behind or right behind the nasal cavity. Where is the nasal cavity? This is the nasal cavity, right? This whole thing is nasal cavity. And right behind the nasal cavity, we have got nasopharynx. This is nasopharynx, right? Below this, we have oropharynx because this is right behind the oral cavity, right? This area is oropharynx. And this area is laryngopharynx because this is in the larynx. This is right behind the larynx. Okay. So this whole thing is pharynx. Cool. Now nasopharynx is bounded anteriorly by the posterior choana. What is choana? Choana is this one. The posterior, let me change the color. The posterior opening of the nasal cavity. As this is the opening, the anterior opening, this is the posterior opening of nasal cavity. That's choana. And the posterior edge of the nasal septum. This is the anterior wall of the nasopharynx. Okay. So the diameter of the nasopharynx, it's 3 centimeter anteriorly. If we talk about like this one, this is 3 centimeter and it's wide. It's wide around 4 to 5 centimeter. Okay. And you see, it has the close proximity to the eustachian tube orifices, the orbits, skull base, maxilla, and intracranial fossa. So that's why there is a diverse range of clinical manifestations of this disease. And the epithelium of nasopharynx varies from stratified squamous to ciliated columnar. Okay, and in between there are transition zones. That's why there are many histological types of malignancy that can arise here. And even there are microscopic, small, countless minor salivary glands, as well as follices are there for lymphoid tissues. What's the etiology of the tumors of the nasopharynx? Just remember 3 words, okay? These are viral, genetics, and environmental. In them also, you have to remember just one word. If it's viral, the cause is EBV, Epstein-Barr virus. If it's genetics, then remember Southeast China, okay? And in environmental, just remember salted fish. Okay, remember this much only. Let's talk about them. So if the viral etiology is there in the nasopharyngeal tumor, the EBV virus will be there. Only one and only cause EBV virus. Okay? EBV virus will be causing 2 types of cancers in the nasopharynx. These are type 2 and type 3. We have some types of the cancer. So histopathology we will be discussing in the next slides. But right now just remember in the type 2 and type 3 of nasopharyngeal tumors. In genetics, you have to remember Southeast China. Why Southeast China? Because there is a genetic predisposition for these people. If these people, let's say, they migrated to any other country, let's say North America or Western Europe, then also they will maintain this predisposition in their life. However, in such situations, that this disease incidence decreases with each new generation. But if these people migrate, this predisposition will not be decreasing. Only the new generation can decrease it slowly. Okay. What's environmental? Environmental means the nasopharyngeal carcinoma, this development is associated with the high dietary intake of salted fish. Why? Because these salted fish, they have the carcinogenic nitrosamines. And due to that, nasopharyngeal carcinoma can occur. Okay? So viral, EBV, genetics, Southeast China, and environment, salted fish. That is it. Now let's talk about histopathology. The great majority of malignancies originate from the squamous mucosa of the nasopharynx. Whenever you think about NPC, the nasopharyngeal carcinoma, think about squamous cell carcinoma because this is the most common one. But others are also there. This is not the only one. We have adenocarcinomas, carcinomas of the salivary gland origin, sarcomas, melanomas, and solid hematological malignancies. Yes, but according to WHO, there are 3 histological types of carcinoma of squamous mucosal origin. What are these 3 types? Type 1 is squamous cell carcinoma. Type 2 is your keratinizing, undifferentiated, complete the spelling, carcinoma. Okay. Third type is non-keratinizing, undifferentiated carcinoma. Yes, these 3 types. See, as I talked about the EBV before, EBV infection can only be causing these 2 types: keratinizing undifferentiated carcinoma and non-keratinizing undifferentiated carcinoma. Okay, the type 1, the squamous cell carcinoma will be just similar type of cancer, just similar. The pathway will be the same as the other head and neck sites and as other head and neck cancers. But keratinizing and non-keratinizing, these are undifferentiated carcinomas. These are due to EBV. Okay. Wherever there is a cancer, there is a staging. So let's stage the primary nasopharyngeal tumors. Start with the T1. T1 means when the tumor involves a nasopharynx alone or nasopharynx and oropharynx. So see, no spread at all. Only in the nasopharynx or nasopharynx and oropharynx. It's there only. It's T1. T2 means the tumor is in parapharyngeal tissue. It has extended in the parapharyngeal tissue, but does not involve the bone. But when it involves the bone or paranasal sinuses, this is T3. Okay, this is spreading slowly, right? Okay. T4 tumor means when the tumor involves a skull base, orbit, hypopharynx, or pterygopenitent fossa. Anything, it is T4. So T1, T2, T3, T4, these are the stagings. Right? In other way, stage 1 would be T1 and node. And node means no lymph nodes are involved. It's stage 1. In stage 2, we don't have any, this is M node, means there is no metastasis. Nodes are may be involved or may not be involved, but there is no metastasis. In stage 3 also we don't have a metastasis. Stage 4A we don't have metastasis. In stage 4B, M node again. But in the 4C, this is the most dangerous condition in which we have the metastasis. T, any stage of N, but we have metastasis. That is the main point here. So stage 1, 2, 3, 4A, 4B, 4C. If you don't remember anything, I don't remember anything. So, but if you want to remember, you can remember. But this one is the easy one, right? This one. Okay. What are the symptoms? Symptoms, how we can remember? See, the nasopharynx tumor is there. So that's why the nasal obstruction, nasal speech, epistaxis, nasal regurgitation of food, these are understandable, right? But what if this nasopharyngeal tumor extends into the orbit? It can cause proptosis or diplopia. No? Right. And if it extends, if it involves the skull base also, it can cause you the chronic headache, right? It can cause you conductive hearing loss. How? Because if this obstruction of the ipsilateral eustachian tube happens, that can lead to the conductive hearing loss due to the middle ear effusion. Right? Okay. Extensive disease of which can invade the maxilla. Due to that, we can have the swelling of the cheek and some dental symptoms. We can have the cranial nerve palsy because it's common. Kind of 20 to 25% of the patients, they have the cranial nerve palsy at the presentation. It could be any cranial nerve, so the patient can have any symptoms related to the cranial nerve such as diplopia. To diagnose the nasopharyngeal tumors, a full ear, nose, throat examination should be augmented with the fiber optic examination. Okay, the first thing, fiber optic examination. Other than that, the patient should be evaluated for the cranial nerve functions, right? CT scan should be done. It can demonstrate the bone involvement or destruction. Other than that, magnetic resonance imaging should be done for demonstrating the soft tissue extent of the disease and involvement of the neurovascular structures and adjacent muscles. Okay, if the patient has the advanced stage, such as stage 3 or 4, PET scan should be done, right? Positron emission tomography. And for the so this can, the PET scan can tell you about the metastasis, the infraclavicular metastasis. It can exclude too. So these are some diagnostic tests you should be done or performed on the patient to diagnose the nasopharyngeal tumors. At last, let's talk about the treatment. So first of all, we have the radiotherapy. The dose of the radiotherapy is 66 to 70 grays in 33 to 35 fractions. Okay, but there are many late complications such as chronic xerostomia. That's why dental evaluation is very important in these patients, because the chronic xerostomia is the most common long-term complaint. Okay, so that's why everyone should be checked before. Chemotherapy we're using, in which we're using the 5-fluorouracil. Okay, but if the stage is 3rd or 4th, the cancer stage is 3rd or 4th, in that case, radiotherapy plus chemotherapy, we are combining both of them, okay, in the late stages. And surgery is not so common in this NPC, because nasopharyngectomy is practiced in some countries, but that has not become the widely established and accepted treatment plan. So, because the neck dissection is needed here, and this should be done only in the tumors which are radio resistant. Okay, it should be proven before by the PET scanning, by the needle aspiration, or by the imaging. And if this tumor is not decreasing by the radiotherapy or chemotherapy, then only the neck dissection should be performed, the surgery should be performed. Other than that, all the patients should be treated with the radio and chemotherapy.